Good morning, good afternoon. Welcome to today's presentation, Learn to Successfully Structure Orientation for Internationally Educated Health Professionals. Before we begin today's presentation, I would like to begin with an acknowledgement that N4 is hosted at CHIO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions across this land. My name is Andrew Tomeyer. I'm the Education Coordinator at N4. I will be hosting and moderating today's presentation. Here today as well, we have my colleague and co-host Colleen Drake, Engagement Coordinator, who will be monitoring the Q&A box today. I'm now pleased to introduce you to today's presenters. Our first presenter is Ndolo Njie-Mokonya, PhD candidate at the University of Ottawa's Health Professions Education with a Master's and Bachelor of Sciences in Nursing. She has been a nurse for over 20 years, and during this time, she's worked in several specialties in hospital and community settings. Her master's thesis explored the experiences of internationally educated nurses' transition experience into the Canadian healthcare systems. She has worked as a nurse educator for the past 6 years at the Ottawa Hospital and a part-time faculty professor with the University of Ottawa. She currently is the coordinator for the SPE program with nursing professional practice at the Ottawa Hospital as well. She is a published author in both academic and professional journals and book chapters, and is very passionate about building capacity and supporting learning for new grads, IENs, and different learner groups. Welcome, Ndolo. Our other presenter, Catherine Driscoll, is a registered nurse working and living in St. John, New Brunswick. Currently working as the IEN coordinator for Horizon Health Network, she helps integrate IENs into the Canadian healthcare system by providing support, education, and mentoring. She is CNA certified in rehabilitation nursing and is nearing completion of her master's in nursing. Welcome as well, Catherine. Our session is being recorded and will be uploaded to our N4 platform within the next week or so. We'll share this with you as soon as it becomes available. Should there be any technical issues during this presentation, we'll inform you with details for an alternate makeup session. And before we begin today's event, I would like to take a moment to introduce you to our platform features to help enhance your participation experience. Throughout today's session, we invite you to write your questions within the Q&A window, and we know sometimes many of you might have the same question or be interested in a particular response. Today, you do have the option to upvote questions. Please upvote questions you would like to hear the answer to, and we'll prioritize accordingly. With that said, our speakers have no conflicts of interest to declare today, and so I will first pass the podium over to Ndolo, and then upon finishing her presentation, we'll pass it over to Catherine, along with about 10 or 15 minutes or so of Q&A at the end. So with that, I will pass it over to Ndolo. Thank you so much for being here today, and take it away.
Thank you, Andrew. All right, welcome everybody. Thank you for having us. So I'm just going to go right into the presentation. I hope everybody can see my screen. I should be in share mode at the moment.
You are in share mode, Ndolo, but please put it into presentation mode as well.
There we go.
Thank you.
All right. So today I will share successful structuring internationally educated health professionals, including IEN's orientation program. And just a brief outline in keeping with the request for the webinar. So just to provide unique experiences, examples of for healthcare organizations who either structure onboarding for IEHP or IENs. And so throughout my presentation, I will share our experiences here at TOH. First, I'll begin with a lit review, which will just describe or situate IEN's experiences when they come into practice areas in the West. I'll talk about practice competency gaps that we've seen, and I will use our supervised practice experience examples. So they are definitely real life examples that I will share with you today. And I'll also describe our TOH model and onboarding practices that we engage in. So the literature is packed with examples of practice challenges that IENs and IEHPs face when they come into practice areas here in the West. And I couldn't get into I couldn't get like exhaust the lit review, but all to say the IENs do face practice challenges when they come into practice areas here in the West. And contributing factors to that is based on some of the reasons anyways, is like differences in skills variation. So just an example here, I have just a snapshot of the pre-screening questions that we have. And we ask these IENs who are um, being screened for the supervised practice experience program, how they see the nurses role. So what's their understanding, or what's their perception of the nurses role? And from there, from that question, you can see just the differences in skills variations. Because here in the West, we have an expanded scope for nurses. We have different pathways. We have medical directives. We have like a certain level of autonomy, which is part of the nursing scope of practice versus international healthcare systems where they just don't have those kinds of expanded scope. They don't have those kinds of skills and competencies as part of their nursing role. Other examples are things like patient and family dynamics. In international healthcare systems, like family members do certain things, basic things like basic care. Like that's something that is not part of the nursing duty. And so, but here, nurses assume that to ensure that the patients get their bath, for instance, or ensure that they have their basic care done. So just those skills variations, skills transfer, just in that, like they do, that would translate or cascade to so many different things. Just being able to handle a patient workload and managing time and prioritizing. So like all of that feeds into the differences in skills variation. Another example is something like TPN, for instance. That could be in some healthcare systems, nurses do that. In some systems, physicians do that, or even blood transfusion. So again, skills variation is it's one of the contributing factor to the challenges that they face. Um, Being able to transfer that skill from where they're coming from to here, and that's just because of differences in equipment and differences in catheters. And so being able to transfer skill from one setting to another, let alone one country to another, obviously could contribute to a practice challenge. And also differences in healthcare systems and different practice models and all of that. So all of that together contributes to the practice challenges that we see with IE and group of nurses as they come into the workplace. So just in terms of this uniqueness of IENs and IEHPs, so our program is based on like there's four main like core competencies, I call it, that we stress on, or that we ensure that it's quite heavy in the onboarding, the intro to SPEP, when I meet with the SPEs that are studying. And again, all of this is based from the literature and all the known practice challenges that IENs are facing when they come into this setting. And again, like I said before, and this is just because of they just haven't had that exposure with this kinds of competencies, right? So they don't have the experience with them. So we try to identify. We identified four main competencies, and interprofessional collaboration, for instance. We do work with a lot of teams involved in patient circle of care. And that's something that's quite unique for the West and not so much internationally. So they're not exposed to all these different teams, social worker and transfer coordinator and discharge. Like there's so many roles involved in patient circle of care that the IENs or IEHPs are not necessarily familiar with or have worked with. And knowing this, we include that as part of our core competencies when we're onboarding them. Effective team communication, problem solving, and clinical reasoning abilities. And again, we might take these things for granted, but that's something that's very basic for us, right? But for if you're coming from healthcare systems that you're not really required to engage in certain decision making, you really will not have those clinical reasoning experience. and also effective prioritization and time management. So these four competencies, I won't say makeup, but they're really heavy on our onboarding with the SBE program here at TOH. And again, it's just based knowing that they don't have either enough exposure with these competencies. So we try to have that as part of our onboarding. So for interprofessional collaboration, so that this is just an example of some skills that the IENs are expected to demonstrate. So they will actively participate and collaborate, reflect on professional behavior and demeanor and their demeanor as it affects the care team. And this is really crucial because some international health professionals or IENs, based on culture, like silence is valued in certain healthcare systems internationally, whereas here in the West, nursing is a very social profession. So if someone that's coming from that kind of a cultural context into a context where the expectation is for you to socialize professionally and to have those verbal exchanges ongoing throughout the rest of your shift about your patients and about different things. It might be a bit of a shock experience, if you will. So just making a conscientious effort to participate verbally. We see that a lot. For some it can be like during that transition period, it's certainly a learning curve for them. So just competency gaps, topics to cover for anyone that's maybe listening and planning to structure their programs as well. So collaborative practice is a huge topic that we lay emphasis on, ensuring that they communicate with the team, and communication is included in this. Just communicating with all the team members that are included in the patient's cycle of care. Autonomous practice. A lot of them are coming from healthcare systems that the physicians is very physician driven. But here, like nursing is an autonomous practice, is an autonomous profession. And so we engage in autonomous practice. And for some of the IENs, if not all of them, that's something that's new for them, and they need to develop those competencies themselves. And also knowledgeable worker. This slide I put here just to help not to forget the preceptors of IENs, because we find that just focuses on the IENs themselves. We found out that the preceptors of IENs equally needed support, and so thinking about them when you're structuring your onboarding programs is really important, and just assist of supporting them to engage in those inquiry conversations with the IENs in placement during their time with them. So for instance, framing needs assessment. So I always try to encourage the preceptors to not say the IENs are struggling. Don't use broad terms, but try to frame it within a specific competency. That way it's easy for you to objectively evaluate them, and also for to provide support. So for instance, like the speech and communication, I noticed, such and such, you're not verbally overt when when you meet the family, for instance, or when you're presenting your patient in Teams rounds or whatever, but just frame it within measurable competency. That way it's easy for both the preceptor and the learner to come up with different strategies for improvement. So the speech communication, the subject knowledge, and this is just content knowledge. It could be management of pneumonia or whatever the subject matter is. Organization skills, again, like I said, they're very time management is a huge struggle area, and that's just because here, like the nurses drive the patient care pretty much, whereas in international systems, like nurses are not that involved. For instance, with basic care, families do basic care. So if they come, that added to everything else they need to do, it's certainly time management is a very basic competency that they really need to learn how to manage their time and prioritize different aspects of the patient's care for the day. And the other one is interprofessional or collaborative practice. So again, this is not so much for the IEN, but just for the preceptor, assisting the IEN during their transition period, in engaging in effective inquiry conversations with them. It could be, you could base this on you could tailor it to your work setting. These are just examples. So I decided to show some practice areas. So at the end of our SPE placements, we send out a survey to all participating SPEP candidates, just to get their feedback. It helps us structure our program and to improve and stuff like that. But this is just a snapshot of learning experiences that some of them, like for some, it was the very first time they encountered these specific learning experiences. But challenging areas for them was like exposure to different learning experience. They had, at TOH, we do use electronic documentation. So that is a huge learning curve for them. So technology use, documentation, and we document comprehensively. Like we document on every single thing. And again, in international systems is not necessarily the case. So knowing what to document, knowing what's important to document or to communicate to one person or another is something that they're finding. It's a new learning experience for sure. Collaborative practice, like professional practice knowledge. And practice knowledge here is just not so much textbook content, but just knowing those micro competencies to your work area. Like pathways, for instance, knowing the different pathways and what criteria are for day one and day two, and like just those things that are part of our hospital culture. So just getting their minds around that and being comfortable with that, and also autonomous practice. So not like just again practice examples, so challenge examples, sorry, practice challenge examples. So at first, one IEN said, I found adjusting to EPIC, which is our electronic documentation, very difficult and frustrating. I worked in the ER back home in a small province, but in Canadian hospital setting is more advanced. So again, technology was a huge overwhelming aspect. Being able to multitask at a given time, again, including just everything about the patient's care, being able to manage that workload was something that they had to learn to overcome. Communication with teams. We also have seen positive, it is not all negative experience. We do have quite a bit of positive experiences as well, actually. So this was a feedback which I thought to add. So all of us enjoyed this particular IEN as part of their team. She became a valuable member of the team. Great manners with patients and staff, very competent and knowledgeable in nursing practice. And she ended this, just FYI, she ended up being recruited, not on this unit per se, or on another unit, but also say we do have positive experiences as well. So the TOH model, so we have two phases. The first is the pre-screen, where we interview the candidates, and the interviewing is just to get a sense of a good fit for them. Like, what unit could this person be a best fit in? Like, what experiences are they coming with? Is it something that we can meet here? Like, for instance, we don't put them in post-op units just because we've seen that just the complexity and acuity of post-op patients was something that the IENs really struggle with. So certain areas we don't place them into. But the whole point of the pre-screening is just to see what units will be a best fit, just to get a sense of their confidence level, get a sense of their personality, and what units we can best place them that would foster their learning experience, I guess, and support it. So once that pre-screening is done, we decide on what unit would be a best fit. We reach out to the managers of this unit, and I do all of that. We reach out to the managers of this unit, and they get recruited. Names are sent to HR, and they're they receive their onboarding letters, like offer letters and stuff. So the onboarding process, they all go through corporate orientation. Some units do corporate unit orientation. Not all units do this because not all SPE candidates are retained. So it's just for better use of educator time. Some do and some don't, but every single one of them goes through a corporate orientation. And then after that, they start their placements on their various units. Midway through, we do a midterm. And the whole purpose of the midterm is just to get them back in a social, in a group, just to get them to reflect on their experiences so far. I get to see if they have any specific questions, if they've seen anything in practice they were not sure about. Just a safe space, I guess, to ask any questions they have, and also to learn from their peers and their work, the different work areas that they're in. For instance, someone in TCU might learn something different about an SBA candidate that's currently in the medicine unit, or on like this, we have a like a step down emerge kind of unit, but also say just to learn about the experiences of their colleagues, and just have that social learning opportunity, and also reflective opportunity for them during the midterm. And the midterm we started the midterm this year. Last year, that was one of the main feedback that we got from the surveys, that they wish they had like a midpoint touch point with me, just to go over certain things. And we've also had cases where they decided on midterm they could not continue. Excuse me, they could not continue the placement just because of like either complexity or for different reasons and stuff. And so the midterm, because once they go out to their placement, it's really hard to follow up because they're all over the place on different units and stuff. So I find the midterm is a really great opportunity to reconnect and see if there's any areas of support, specific support we can offer. And then there's the end of the placement, which we usually coach for interviews, just in preparation for recruitment for those that have job offers pending. So we have that kind of a support as well. Just generally what some things to anticipate, and just to, just pick their brains a little bit, and some things to think about for nurses that would work in this area versus that area and stuff. So that's pretty much the TOH model. It's like we have didactic, it's composed of a didactic component. We use a lot of case scenarios just to get them aware of practice expectations that they will see on the units. So we do use a lot of case scenarios, and we have our discussions. This is where we try to include all the 4 core competencies that I've mentioned before in these scenarios, and we get the IENs to tease those competencies out to see, just to get their understanding, and also to give them an awareness of what those practice expectations will be. That way, as they're returning into practice, they know, okay, this is what I really need to engage my mind or get myself into a mindset or frame of mind to return to professional practice, especially since they've been out of practice for 3 to 5 years. We also have simulation included in our onboarding, and also like on the unit support. So TOH has clinical preceptors, we have coaches, we have the SPE coordinator, myself. So I work really closely with the preceptors because, again, we found that the preceptors needed a significant amount of support as well. So I give them different strategies on how to ask different questions. You saw this, and can you relate it to what you saw yesterday, and how did that change, and like just to engage them cognitively. That way they can create those memories and be familiar with what those expectations are. So at TOH, so we promote a culture of acceptance, preceptor readiness, unit team. So we try as much as possible to put them on units that we feel will be a best fit. For the most part, we've been successful, but sometimes you like meeting someone virtually on an interview, pre-screen might be a different personality once they actually get on the unit, right? So sometimes we've had a few misses here and there. But this just shows like the different units that we use. Like we use TCU units, mental health units, medicine units, radonc, rehab, ortho. Ortho is the only post-op unit that we use. We don't send them to gen surge. It's just too complex. And the patient's acuity level is really high and high on unpredictability and stuff like that. So just for safety reasons, and also just not a great learning experience for them as well. And also dialysis units. So hemodialysis units is one of the units that we use for the placements for them. So recently, our SPE program, we had a publication which we're trying as much as the whole purpose of including it for this presentation is we're trying to get the public to think of workplaces as a really valuable uh, place for bridging programs, because we find a lot of the bridging programs are pre-hire or like during the education phase and not so much in the workplace. And that's really where they find these real life practice experiences and having to apply skills transfer. And so having bridging programs within the workplaces is something where we saw as really valuable. Just speaking in terms of the SPE placements, that program that we have now, and we wish more hours could be added to it just to get these IENs into more specialty areas and just to improve their readiness for practice, really. So just a few takeaways. So just recognize the IEHP or your IEN learning zone and support knowledge application for them in these areas. Prepare the preceptors as well, because preceptors, they're the facilitators of those learning experiences. And so not thinking about them when planning could lead to different frustrations. And also promote their participation and involvement. So the IENs need to, in our program, they take on an active role, and I strongly encourage them to take on an active role in their learning. They identify learning plans, they engage in reflective practice with me, but they really need to have that mindset of professional practice. Returning into practice after being out of practice for 3 to 5 years is not just something that you will just walk into work and expect someone to show you how things are done. You also have to be take on an active learner role as well. So just a few takeaways for me, and that's the end.
Thank you, Ndolo. Excellent presentation, and we definitely will include the journal article that you shared with the supplementary materials of this webinar recording as well. And with that, feel free, if you have any questions after the presentation as well, feel free to contact Ndolo at the email below. Along with that, we'll pass it over to Catherine Driscoll. Thank you again, and feel free to take it away.
Okay, thank you. Just share my screen. Sorry, I'm only seeing, only one of my screens is working.
Oh,
hold on.
there we go.
There.
Excellent.
It's working? Perfect.
Yep.
Okay, thank you. Hi, everybody. My name is Catherine. Great presentation, Ndolo. It really kind of validated a lot of what we are seeing here in Horizon here in New Brunswick. So yes, I work with all the international nurses who come into Horizon Health Network in New Brunswick. I am located in St. John. And okay. So to start, I wanted to give a little bit of background. So I guess I will kind of preface by saying most of what Ndolo talked about is exactly what we have learned along the way here. My presentation, I did focus a little bit more on what I include in IEN orientation, but I just want to start with a little bit of background. So prior to October 2021, New Brunswick would see maybe 5 IENs being registered to work here. The registration process, along with a new recruitment strategy, has brought this number from about 5 a year to now well over 100. The change in registration allowed many IENs to challenge the NCLEX exam, which meant that when they arrived for their first orientation shift on their unit, this was often their first time stepping foot in a Canadian hospital. Most of our IENs do not have any bridging courses that they've taken or any type of clinical or preceptorship. At the time, I don't think we realized just what the learning needs would be and how our mentorship would have to change. So I was working as an educator when one of our first IENs started back in December of 2021, and I had to Google what an IEN was. I was just told, we're getting some IENs. I didn't really know what that meant, and I did a lot of research. And when I kind of look back on that time, it really speaks to the resiliency this group had, or this group has. As the educator, staff would come to me with their concerns, and it would be things like, not knowing how to use the beds, the call bell system, how to get a hold of a doctor. We quickly learned that, we very much took for granted that most of our newly hired staff did their clinicals and preceptorships in our hospitals, and that our typical on-the-job orientation was not going to work. Unfortunately, January 2021, COVID really hit our province, and I was redeployed to work the front line, which did give me the opportunity to work alongside these newly hired IENs and really get an idea of how I could better help them once this redeployment ended. So in May 2021, with the amount of newly hired IENs entering Horizon, they did create this position, the IEN coordinator, and I was the successful applicant. And there was a lot of catching up to do as IENs were entering our workforce months before this role was even created. And one of the first things that I did was to create an IEN orientation to try to give all IENs some of what we would consider that basic or generalized information prior to starting on a unit. So before I get into the content of the orientation, I do want to start by addressing a few things that we did learn along the way. First, I always like to make it clear that, when I refer to IENs or they or them, that I really don't mean to generalize or imply that it's all IENs. I think as many of us know, it is a challenge to generalize as everyone comes from such diverse backgrounds in education. The second thing I want to just jump in and address is that overall, New Brunswick is perhaps not as diverse as other larger cities or provinces in Canada, and we do have some work to do in this area. Horizon is putting a lot of work into diversity, equity, and inclusion, and that includes hiring a regional project manager for DEI initiatives. And very similar to what Ndolo was saying, I also want to add that we have done a lot of work to better prepare staff for mentoring IENs. We created an IEN mentor toolkit, which offers a lot of resources, expectations, cultural differences they may encounter. We also have mentoring IEN workshops that gives more information on cultural differences, being more aware of our own culture so we can identify those differences, and information on the mentoring process. I'm always wanting to hear from the IENs so that their voices are heard. So their feedback was also included in this workshop. And again, similar to Ndolo, I have sent out some anonymous surveys to try to get feedback from them as well about their onboarding experience. I feel this all goes hand in hand with a good comprehensive orientation because we want to make sure that they are being fairly evaluated. And I say this because in the beginning, it was typically the same few concerns that were brought forward. And despite trying to educate and mentor the Canadian educated nurses on cultural differences and what to expect, often it was the same concerns that kept getting brought up. What we would hear, it doesn't appear that they understand what I'm saying. Or if asked if they understand or asked to do something, they will say yes and then not do it. Critical thinking is a challenge. And actually, I love how Ndolo reworded that about clinical reasoning abilities, because I think that's it. It's knowing what the scope of practice is as an RN in New Brunswick. Because if you do give a scenario and you say, okay, what are you going to do? I'm going to call the physician. Well, that might be how it was where, you worked previously, but there's a lot we can do within our scope before we get to that point. So I think that right there is a huge learning curve. And we tend to just kind of jump to the critical thinking as a challenge. Other things, they are quiet, they keep to themselves, they're isolated from other staff. There's no sense of urgency when things are going bad. And again, I very much want to stress it's not every IEN, but these are some of the common comments that were being brought forward. And all of this can be understood with cultural competency and sensitivity training. So we do work hard to bring this cultural awareness education to all of our staff. Okay, so getting back to the orientation piece. So Horizon Health has 12 hospitals and many rural health centers. Excuse me, I cover all facilities within the Horizon Health network. So because we are all spread out, it made the most sense to make this a virtual session. So everything that is included in this virtual orientation is based off of feedback from managers, staff, the IENs themselves on what appears to be missing or what appears to be the gaps. So this is the agenda that I go over for orientation, and there is a lot that we discuss within these topics, and I'm just going to go over some highlights. So I talked briefly about Canadian healthcare, which includes a short video that summarizes our healthcare system pretty well. I used to go into a lot more detail, but found for an initial introduction, it really didn't need to get that deep. I also explained specifically what Medicare looks like within New Brunswick and what is and what's not included, as this varies by province. The last line of this says that supplemental insurance is strongly recommended, and this opens up the conversation to talk about private insurance, and specifically for us here, it's Blue Cross and the life insurance and pension plans that Horizon offers. I've heard from many IENs that they don't really know what a pension is or weren't exactly sure what Blue Cross would cover or if it's worth it. So this helps open up that conversation to better explain what this all means. I try not to assume what some know or may not know about Canada, so I always speak on these potentially controversial topics because I want them to be aware in case the patient brings it up to them. In particular, medical assistance in dying. This is often not something they have seen before. I don't want them to feel blindsided if a patient brings in their cannabis gummies as a home medication or asks for harm reduction supplies. Depending on where they previously lived, some of these would be illegal or potentially non-existent. I also take time to make sure they know how to access healthcare for themselves. I explain the process of applying for a Medicare card, getting their name on the wait list for a family doctor, and what options they have if they need to seek healthcare if they don't have a family doctor. I really stress the importance of seeking healthcare even if their Medicare number hasn't arrived yet, and explain the reimbursement process. I then go over some New Brunswick specific information. So we do have 2 regional health authorities in New Brunswick, Horizon Health, as well as Vitalité, which is the French speaking regional health authority. We do a lot of transferring between our hospitals here in New Brunswick because we have so many small rural facilities. So for example, St. John, we have the heart center of the province. So anybody requiring a heart procedure is transferred to St. John. And that includes those in the Vitalité Regional Health Authority as well. We discuss the terminology of what a home hospital means, waiting for placement, being medically discharged, and go over the differences between a nursing home and special care home. I use this quote here as our starting point for this section and ask, if you were working right now and you heard this statement, the patient is now medically discharged, he's being transferred to the deck while waiting for placement, would you know what this means? The deck is our Fredericton Hospital, so I'm not really expecting anybody here to know that, but and you can let me know if the rest of the terminology is Canada-wide or not. But I do find with this statement, about half know what maybe waiting for placement means. That means waiting for a nursing home, but often the DEC and medically discharged are new terms. So then we go into more detail on these topics and this terminology and how this kind of plays out when you're working as a nurse. We then talk a bit about what to expect working alongside Canadian educated nurses and what some of our work traits might be. I've had IENs be very taken aback with how assertive nurses are when speaking to patients and doctors. If their previous work environment was very physician-led, knowing that they now have a voice and are expected to advocate, it can be a challenge. And our doctors are also not on the units most of the time. We've had IENs ask, "Where are your doctors?" So we spend some time talking about how these may be cultural differences from what they have seen with past employers. I try to give some insight into our working culture and how it may differ compared to other countries. Similar to the cultural awareness training I do for the Canadian educated nurses to understand other cultures, I do the same here as well for them to try to understand ours. Language is the biggest barrier IENs encounter, so we do spend some time talking about language. With New Brunswick being bilingual, we do greet all of our patients in French and English, and we go over what this means if you don't speak French. We do have language supports, both in French and English, through our official languages department, and we discuss what these supports look like and who to contact. Another part of language that I always like to mention is that we have a policy that says English is the official language for charting, internal communications, memos. However, our official languages policy states that you are able to speak any language as long as you exercise good judgment in considering their environment and how it might impact staff and patients. So as long as you're not talking over a patient in another language or giving vital information to another nurse, you can speak in the language of your choice within any of our facilities. A big part of the language barrier is learning our own colloquialisms and sayings. So to kind of lighten things up, I do start by asking, has anybody heard a Canadian say "a" yet? And of course, talk about the loony and the toonie. I would say most of our IENs are only in Canada a few days or maybe weeks before they actually start working. So many of these common to us sayings are quite new for them. Another challenge when it comes to language is learning our terminology and name of supplies and equipment. So these are the examples that I use. I start by saying, if someone asks you to grab a 2x2, what are you going to grab? And I would say that this is fairly universal. About 75% know that we're talking about gauze. Then I ask about this middle picture, and I get a lot of, it's a blanket, a sheet, a drape. Every so often, someone will call it a flannel, which is what we call it here. And then the last one, it gets a very wide range of answers: an oxygen adapter, a nipple, a spigot. I call it a Christmas tree, and many of the nurses I work with also call it this. I think I've only had maybe 3 to 4 IENs who have called it this at their previous employer. I use these examples to bring attention to just how much might be different, and I encourage them to spend time learning the names of our supplies, equipment, and really encourage to ask questions if they hear a term that is unfamiliar. I really, really stress the importance of asking questions. This shows that initiative that is important to our Canadian work culture. I then briefly talk about our provincial professional regulation or associations and how, as registered nurses, we follow the Canadian Nurses Association Code of Ethics. I send them a link and encourage them to read through it to become familiar with the document and expectations of a registered nurse here in Canada. Most of our IENs have never been part of a union. I give a brief introduction to what the union does and also go over a few key points of the collective agreement, such as vacation, sick time, that things like how long our breaks are, that they're all outlined in this document. I also strongly encourage them to reach out to their local union rep so that they have a contact person to help try to understand the collective agreement, because it can be quite legal terminology. There is also quite of hospital-specific information that we do review, including defining the roles of PCAs, LPNs, and RNs, and what that looks like within the scope of practice of an RN here in New Brunswick. We do go over documentation and what is the expectation of charting within our facilities. We review Skyline, which is our intranet where all of our policies and internal communications can be found. We then review a pay stub, as this can be quite the complicated process with all the different codes that are used. The other thing we created was this orientation flow chart. We were finding that even though we were speaking with the nurse manager or the nurse mentoring the IEN, that expectations were not always clear. Some mentors didn't fully understand the learning needs and had higher expectations than what was feasible for being brand new to Canadian healthcare. In order for the IEN and their mentor to be clear on expectations, we created this to help guide the clinical portion of orientation. We also created a learning day wherein IEN could come into a controlled learning environment to have hands-on practice with equipment such as the IV pumps, mixing IV medications, the enteral feeding kangaroo pumps, and peripheral IV insertion. The equipment is often not the same, and this gives them some time to get used to the equipment and get a bit more familiar with it. We also recently added a documentation workshop that reviews our documentation standards, gives some real life examples, and has them practice charting the scenario. And last, I just want to talk a little bit about the support that we offer. So there is a Facebook group that was created specifically for the IENs working within Horizon. It's just a place for them to meet others going through the same process, a place to ask questions or to advertise upcoming educational opportunities. Horizon also has a mentorship team. And our nurse mentor coordinators reach out to all new hires and follow up with them and their mentors frequently throughout orientation and their first year of employment. I work very closely with the nurse mentor coordinators as they are the ones in each of the individual hospitals meeting the IENs face-to-face. They build those relationships and trust so that if there are issues that arise, there is that safe person they can turn to if they don't feel comfortable going to their manager. I couldn't do this job without them. Again, I'm a regional position, so I'm for all the facilities, but they're my boots on the ground team. So these were some of the highlights that I wanted to go over. This has been ever evolving over the past year and a half. I'm always incorporating feedback and fine tuning this orientation. It's a lot of information that they get during orientation. So I always send a follow-up email with a copy of the PowerPoint presentation that I use, all the resources we discussed, just so that they have a copy that they can go back and review. I will say this is all going to be changing again because our regulatory body has actually changed registration requirements. So now most of our IENs will require coursework and clinical hours. So I think it'll look a little bit more similar to what Ndolo was talking about. So they'll have to complete this before they receive their registration. And the hope is to increase the classroom and skills time before starting on a unit, just so that they are better prepared and so that their mentors are a little bit more prepared as well. So in the meantime, we are creating that new orientation, and I am working with our DEI project manager to continue promoting DEI initiatives, hosting cultural sensitivity workshops, lunch and learns, in addition to our mentoring workshop. Thank you.
Thank you, Catherine. Excellent presentation. It was very interesting to hear the perspective from not just the big learning elements, but also even the little small ones, like related to the flannel and the Christmas tree elements. So now we've got a few questions and answers, or questions for our speakers here, both Ndolo and Catherine. So the first one I have here is, are you seeing significant correlations? This one for Ndolo. Are you seeing significant correlations between time out of practice to success in practice after SPE completion?
Oh, absolutely. Yes. Yeah. The more like those that are now the SPE program, our experiences are based off from the supervised practice experience program, and the candidates that are coming into this program have been out of practice for a minimum of 3 years. We're even saying 5 years out of practice, and so based on their prior experience, that has a lot, probably a higher correlation to success, if you will. But definitely, time out of practice is a huge, huge contributor to success. I hope that answers the question.
Yes, thank you. This one is directed to Catherine. How long is the IEN orientation that's provided at Horizon?
So the virtual orientation that I do, it's not quite a full day. I found it was if it's too long, it's too much. It's too much information. So it's about a half a day for the virtual orientation piece, and then their on-the-job clinical component is about 450 hours, and it gets extended as needed once we kind of check in. And again, we're checking in throughout. So sometimes it can be upwards of 800 orientation hours. It just depends on the unit they're working on and how they're doing.
So thank you. Thank you. This one's directed to both. With regards to the surveying IENs about challenges faced in the workplace, do you have any sort of sample questions that you use when surveying IENs?
Well, the survey we asked, the purpose of the survey, especially to find out about their practice challenge areas, is so that I know how to tailor my clinical scenario examples. So that's the purpose of the survey question, just in terms of practice challenges. So it's a very broad question. Like you saw the criterias in the slide I had, there was autonomous practice, and I based my options based on the known practice challenges that has been identified in literature already. For instance, the autonomous practice, collaborative practice, practice learning, like knowledge, and specifically content knowledge, because if they go to different specialties, obviously it will be different in dialysis versus a general medicine unit versus a TCU. So it's just to know what their specific practice challenge areas are. And if I see a trend in that, then I can make a scenario about this particular thing. So that's the purpose of the survey question.
I've done a few over the past year and a half, and it's really depending on, what I need to know. Sometimes it's what would you like to see included in IEN orientation? Is this just too much? And that's sort of why I had to narrow it down, because it was just way too much information. I've sent out a 1-question survey just saying, do you feel comfortable asking your coworkers for help if you need it? Because that's something that kept coming up is, if they're not asking questions, is it because they're not comfortable, or is it a cultural thing? Like, we just to try to get to the root of it. I will also say that our DEI, our new department, they actually just put out a survey to all the IENs, and we did get overall very positive feedback that they feel supported, that the onboarding experience was good. So they had some specific questions as well. I don't know if I can speak to them because I didn't create them, but I think it really just depends on what you're looking for. But that's sort of really, it just depends on kind of what I'm looking for feedback. What would you like to see in additional education? What would you like us to work on? Like, how can we help you? Because sometimes they just need that anonymity to speak freely.
Right, of course, and we can touch base after to look at the literature that was used in terms of determining potential questionnaires and include this with the supplementary materials, so we can take that offline as well. This question is for Ndolo. Within the TOH model, do you avoid acute floors such as fast-paced medical units and focus on more units such as hemodialysis and ambulatory care, or do you throw them into the jungle?
No, we don't. We don't throw them into the jungle. Because primarily because it's really not a good, if we put you in a unit that is, the patients are very complex and they have high acuity levels, very unpredictable, it's not a suitable environment for a learner. Number one, your preceptor will not have time to sit with you and really go over the case scenarios with you. This is what's going on with this patient. This is why, because like research shows that nurses identify primarily as clinicians and not so much educators or teachers. So if something is going on with the patients take priority and not the learner. So you don't want to put them in a situation where they're not gonna, it will not foster their learning experience. What I tell the IENs is you have the rest of your career to build it. Right now, focus on coming into practice safely. So we want to put you in a unit where patients are stable, acute but stable. So you will see the fun things, you will see the race experience and all of that, but we're still not throwing you in the jungle, like you said, just to have a chance to reinforce those safety components that are important for you as you return into practice, and you build up your, they will grow and they will branch out to different specialties in a year or two. And so, but it's just a staging process, I guess.
Of course. So then over time, it sounds like then even potentially working within the emergency department, the ICU,
Oh,
with
absolutely.
time and experience.
We've seen SPEPs that started on a relatively stable unit, and after 6 months or so, they go into PACU, for instance. I have a couple in mind that currently work in a PACU unit. So it's just to start off. Like safety is key, and I really stress that for them. You've worked this hard to get your license, keep it. So we stress on safe practice. So whatever that takes for you to return to practice safely is what we foster during that placement time.
Thank you. This one for Catherine. At Horizon Health in the orientation, does it also cover all other elements that a domestically trained nurse would receive if you've had, and also if you had all your wishes, what would you add to the program?
Yeah, I think, I mean, here in New Brunswick, we're a lot smaller. Our resources are pretty limited. And this is sort of looking back, and they were just kind of showing up, and on the job training was all that was being done. Ideally, we could do a lot more. And that was actually some of the feedback we were getting from some of the nurses mentoring, is that this feels like we're teaching them the 4-year undergrad program. And so that's sort of where things like the learning day came in, where we did go over a physical assessment. We did the IV pumps that we use here in this hospital and that sort of thing, because we wanted to try to get a little bit more of that education up front. I think with so the way that it's going to be changing now is that they will require 600 clinical hours before they get their RN registration. They'll have a conditional license in the meantime. And that's where we're really going to, I think, be able to try to incorporate a lot more of what a domestic a nurse would learn, go into a lot more detail about the systems. We hear is very similar to what Ndolo said about the morning care, basic care, about we do get IENs who have never washed up a patient. Same thing with things like listening to lung sounds. That's not a universal scope of practice of an RN. So being able to give a little bit more of that focused education on the things that we know are needed, instead of relying on the nurses who are already working short-staffed and they're still trying to give all this education. So that's kind of my wish list. I think my wish list I've already kind of made in preparation for this change with our association.
Thank you. Thank you. And before we wrap things up, is there any key takeaway messages that you would like to share with the audience before I jump into our final slides?
Well, I'll go. Well, key message for me is, speaking to the IEN specifically, returning to practice. I know, like, you're new to whatever province you find yourself in, and you're working towards getting your license. Like, returning into practice is like I mentioned in my presentation, take on an active learner role. Like, it's not things that will just sink in by osmosis. Like, you have to take on an active role. If that means coming early to get your patient assignment, to get you caught up, then do so for the first few bit until you get caught up. If that means reading before coming to clinical, read before coming to clinic. But you have to take on an active role, because it's not like professional practice is not as it is internationally. So you really need to be able to actively integrate into the system.
And I'll just add, they're such an incredible group of people. They're always so grateful. They're so kind. I really hope that we can kind of shift the cultural component a little bit more, so that everybody's just a little bit more accepting and understanding and showing some more empathy.
Thank you. And thank you so much both for being available for this webinar today. And I will share my screen and we can present and wrap things up. So first things first, we have, just to connect it all, we've recently launched a checklist for recruiting and integrating and retaining IEHPs. And this downloadable checklist was created with healthcare employers across Canada and can be used by all within the healthcare sector to help create a workplace that's welcoming and ensuring a sense of belonging for our IEHPs. We have a QR code here, as well as the link available in our IEHP toolkit, and I believe Colleen will be sharing a link within the chat as well. Along with that, once more, thank you so much, Catherine and Ndolo, for taking time to participate in today's discussion, and many thanks to you, the audience, for joining with us and engaging with us today. You're welcome to join us again very much for any of our upcoming events and webinars as well in December and going into 2024. And if you missed any part of today's presentation, or would like to be watching this session once more, we'll be posting this recording to our N4 platform within the next week or so. We very much want to continue the dialogue that's been happening within this presentation. And so with the presentation being posted to our website, it will be included in our meeting place to bring forward any sort of chat, any sort of discussion that folks would like to be involved with regards to this topic. We'll be moving those questions as well that we didn't get a chance to address to the discussion forum as well. And we've invited our presenters to respond to your questions there. We've curated several resources related to today's presentation topic as well. They can be found in the resource toolkit, and we will share them with you when we post the on-demand version of this discussion. So if you haven't yet, please sign up to newcomernavigation.ca for all our resources and learning opportunities. And along with that, feel free to check out our mobile app available on Apple and Android devices through the QR code here, or by going to newcomernavigation.ca/iOS or Android. And thank you so much again, everybody. Thank you for joining us. We hope to see you again at a future N4 event. And stay safe and stay well, everybody. Take care.
Bye, everyone.